You know what's scarier than a horror movie? Having perfectly normal-looking patients suddenly develop seizures and fall into a coma. Today, we're diving deep into hyponatremia, the most common electrolyte disorder that affects up to 35% of hospitalized patients. By the end of this episode, you'll understand how to diagnose it, treat it, and ace those tricky NEET PG questions.
And it's not just about memorizing numbers. This is about understanding a condition that can literally make brain cells swell until they burst.
Wait, brain cells actually burst? That's terrifying! Let's start with the basics. What exactly is hyponatremia?
So, hyponatremia is defined as serum sodium less than 135 milliequivalents per litre. But here's what makes it tricky. It's usually not about not having enough sodium, it's about having too much water relative to sodium.
Ah, so it's more about dilution than depletion?
Exactly. And according to recent research, we can classify it into three main types based on volume status: hypovolemic, euvolemic, and hypervolemic hyponatremia.
Could you break those down for us?
Sure. Think of it this way. In hypovolemic hyponatremia, you've lost both water and sodium, but you've lost more sodium. Common causes include vomiting, diarrhea, and diuretic use.
Okay, that makes sense. What about euvolemic?
Euvolemic hyponatremia is fascinating because the total body sodium is normal, but there's excess water. The most common cause is SIADH, syndrome of inappropriate antidiuretic hormone secretion.
And hypervolemic must mean too much of both?
Well, here's where it gets interesting. In hypovolemic hyponatremia, you have increased total body sodium and increased total body water, but the increase in water is proportionally greater. You see this in heart failure, cirrhosis, and kidney failure.
That's actually mind-bending. You can have too much sodium and still have hyponatremia?
Exactly. And here's something that often comes up in NEET PG. You need to check both serum and urine osmolality, along with urine sodium, to differentiate between these types.
Let's talk about symptoms. What should clinicians be looking out for?
According to recent studies, symptoms really depend on two factors: how severe the hyponatremia is and how quickly it developed.
Oh, so timing matters?
Absolutely. Acute hyponatremia, developing in less than 48 hours, is much more dangerous. You can see severe symptoms even with moderate drops in sodium because the brain hasn't had time to adapt.
What kind of severe symptoms are we talking about?
The most concerning are seizures, delirium, and coma. But you can also see headache, vomiting, and something really interesting called neurogenic pulmonary edema.
Neurogenic pulmonary edema? That sounds serious.
It is. It's particularly seen after endurance sports or, interestingly, after ecstasy use. But here's something fascinating. Even mild chronic hyponatremia can cause problems.
Really? What kind of problems?
Recent research shows that even mild hyponatremia increases fall risk. In one study, patients with hyponatremia had a 23.8% history of falls compared to 16.4% in those with normal sodium levels.
That's a significant difference. But why would low sodium cause falls?
It affects cognitive function and gait stability. And here's something most people don't know. It's actually a secondary cause of osteoporosis.
Wait, what? Low sodium causes bone problems?
Yes. The same study showed that over a 7.4-year follow-up, hyponatremic patients had a 23.3% fracture rate compared to 17.3% in those with normal sodium.
Let's talk treatment. How do you approach it?
The key is not to correct too quickly. According to current guidelines, you shouldn't increase sodium by more than 8-10 milliequivalents per litre in 24 hours.
Why not? Wouldn't faster be better?
Actually, rapid correction can cause something called osmotic demyelination syndrome, which can be devastating.
That sounds scary. What exactly happens?
The brain cells have adapted to the low sodium by accumulating organic osmoles. If you correct too quickly, they can't readjust fast enough, leading to permanent neurological damage.
So how do you treat it safely?
For severe symptomatic cases, we use 3% hypertonic saline at 0.5, 1 milliliter a kg an hour. The goal is to increase sodium by 4-6 milliequivalents in the first few hours to relieve symptoms.
And for less severe cases?
It depends on the cause. For AH, fluid restriction is often the first step. Some patients might need medications like tolvaptan, though we have to monitor liver function with that.
Speaking of monitoring, what labs do we need to keep track of?
3 essential tests: serum osmolality, urine osmolality, and urine sodium. These help determine the underlying cause and guide treatment.
And how often should we check sodium levels during treatment?
For severe cases, every 6-8 hours. Recent studies show that close monitoring significantly improves outcomes.
Are there any special populations we need to be extra careful with?
Yes, elderly patients are particularly vulnerable. According to recent data, 54% of hospitalized hyponatremic patients are over 60 years old.
Why are older patients more at risk?
Multiple factors. They often take medications that can cause hyponatremia, like diuretics, and they may have decreased thirst sensation and impaired kidney function.
Let's talk about some common pitfalls. What mistakes do you see people making?
One big mistake is not considering pseudo-hyponatremia. If a patient has very high triglycerides or proteins, it can falsely lower the sodium reading.
Oh, that's interesting. Any other common errors?
Another is using normal saline for all cases. In SIADH, it can actually make things worse because the body will retain the water and excrete the sodium.
That's counterintuitive. Any other surprising facts about hyponatremia?
Here's one that often comes up in exams: hypertonic hyponatremia. It's when the sodium is low, but the osmolality is high, typically seen in severe hypoglycemia.
So the sodium is actually normal, it just looks low?
Exactly. For every 100 mg/dL increase in glucose above normal, the sodium appears to decrease by about 1.6 milliequivalents per liter.
That's a great NEET PG pearl. Any others?
Yes, remember that certain drugs can cause IH, particularly some antidepressants and antipsychotics. It's a common exam question.
Speaking of exams, any tips for approaching hyponatremia questions?
Always start with volume status. Is the patient hypovolemic, euvolemic, or hypervolemic? Then look at urine sodium and osmolality. The pattern will lead you to the diagnosis.
That's really helpful. Any final pearls of wisdom?
Yes, remember that hyponatremia is often multifactorial. Don't stop at finding one cause, look for others. And always check medication lists.
And what about prevention? Any strategies there?
Regular monitoring of at-risk patients is key. Recent studies show that early specialist input and clear communication across healthcare teams significantly improve outcomes.
This has been incredibly informative. Any last thoughts?
Just remember, respect hyponatremia. It's common enough to see frequently, but serious enough to kill if mismanaged. Take your time with diagnosis and correction.
Well, that brings us to the end of today's episode of Copilot Podcasts. Remember, when it comes to sodium, slow and steady wins the race. Unless there are severe symptoms, then you need to act fast, but still carefully.
And just like how too much water can dilute sodium, too much information can dilute understanding. Focus on the basics: volume status, rate of development, and careful correction.
Thanks for joining us on this deep dive into hyponatremia. Until next time, keep your sodium levels balanced and your knowledge sharp.